excited that everybody made this happen. So today we've got Carrie and Patty and Hannah and Candy all talking about trauma-informed care, which is really important in our business. We've got a lot of new pregnant people and with lots of trauma coming along the way. And so this is really, really important. Also just pregnancy in general and substance use disorder, and what we as nurses can do to combine all of those things to help make a better experience for these people and hopefully maybe catch them when they're at this very vulnerable time and help make a difference for them. So I will give it to Patty. Go ahead, babe.
Thank you. Just a couple of really quick housekeeping items. So if you could please mute yourselves, because that helps reduce background noise and it helps us hear each other a lot more clearly. That would be great. And then this webinar is going to be recorded so that you can have access to it and other people who couldn't make it today can have access to it. So we're going to record it and make that available for you. Also, these slides will be available for you. And also, I just really want to encourage you to please chime in. Please either, raise your hand. There's that functionality in Zoom to raise your hand, or type directly into the chat room. Or if you don't know how to do any of those things and don't want to bother, just ask a question. We want to make this as interactive as possible, so please feel free to ask at any point. And then I'm gonna just go through introductions here really quick before we get into the content. Carrie, would you like to start?
Sure. My name is Carrie Griffin. I am a family medicine OB physician who is addiction board eligible, and I practice at United Indian Health with Open Arms and a soon-to-be future practice with Open Door at St. Joseph's Hospital.
Thanks, Carrie. Do we have Candy on the line?
Hi, Patty. This is Candy Stockton. I'm a family medicine doctor who's double boarded in addiction medicine, and I am the Chief Medical Officer at the Humboldt IPA and practice at our Priority Care Center.
So there's no video on. And
Hannah?
I want to make sure that the audio.
Hey everybody, I'm Hannah Lippy. I'm the social worker for this project. I'm over at St. Joe's. Welcome.
And I'm Patty Torres. I'm the project manager for the Humboldt Rides project. I also wanted just to give a brief background on who we are and what this project is. So this is a grant-funded project by the Wellbeing Trust. It started in 2018, although this sort of implementation phase is a continuation from work that started back in 2016 to address high rates of substance use in pregnant women in Humboldt County. It's supported by a cross-organization project team, so we're really proud to work closely with St. Joseph Hospital, First Five, the County of Humboldt, and CCRP, the California Center for Rural Policy. The backbone organization for this project is the North Coast Health Improvement and Information Network, NCHIN for short. And the four main priority areas here are implementing screening universally for every pregnant woman upon entry to prenatal care, establishing a perinatal care navigator, that's Hannah's role, and then increasing access to treatment for pregnant women who have substance use disorder, and working to sort of have community messaging and norms around cannabis use. And so what we learned from implementing these goals is that there's a lot of desire for education around topics such as trauma responsive care. And so here we're hoping that we can deliver something that's useful, and please, like I said, ask any questions at any point. So with that, I'm gonna hand it over to Carrie.
Great. I just have to say, I am so delighted after being in Crescent City and at Sutter Coast for 2 weeks. It is so nice to see all of your faces and even just your names. So, and this is obviously a topic that I really care about. And I will say that the values of Mad River in particular are so rooted in a woman's autonomy that trauma-informed care is really an extension of that way of rendering care to people. So what we hope that you'll be able to experience as a part of this hour is learning how to apply concepts of trauma-informed care to the daily lived in, lived out interactions that we have with patients, and how to identify signs of trauma. So identifying what we're going to talk about as nervous system dysregulation, and then what are some very tangible skills that you can walk away with to manage these kinds of situations when someone's trauma has become activated. Next slide. So what is trauma? Trauma is one of those words that's a little bit like love or hate or anger. You know it when you feel it. We know when we've witnessed trauma. We know when we've experienced it. Overall, we would define it as something that overwhelms our nervous system, a moment where we've experienced or we've perceived that we've experienced direct threat, harm, or potential loss of life. And loss of life can come in a lot of different ways. That may mean physical, or it may just mean your emotional well-being. This could be a single shock event, like a car accident, a drowning, a fall, or it can be a series of interactions, such as in the case of developmental trauma. So growing up in a home with addiction, with physical violence, any of the adverse childhood events, that 9-point screening that we've talked about as a county in different ways, in which the state of California has developed a screening tool for. Any of those events, when we're exposed to them over time, create chronic dysregulation in our nervous systems. The reason this is a problem is that when we're constantly dealing with some kind of onslaught, some way in which we feel like we're threatened, or we're not enough, or we're not safe, eventually your ability to cope with that is harmed. And people begin to develop strategies to cope with the sense of, I can't get out of here, I'm trapped in this situation, I'm completely shut down, that can logically affect their health. But in the moment, when you're just trying to cope, when that moment and that series of moments, if you're still living in a dysfunctional home, are about survival, we make the choices we make in order to manage the nervous systems we've been dealt with. Next slide. So why do we care? On some level, this seems self-evident, but I always like to go back and really touch the big picture. What is this all about? Well, for patients who have a substance use disorder is one of the most common ways to cope with a heavy trauma burden. Furthermore, a traumatized individual is very likely to be living and feeling with those chronic nervous system patterns that are dysregulated in their body all the time, and anything outside of them might ignite that feeling. So to break that down a little bit more, let's go back to physiology and talk about the autonomic nervous system. So there's the sympathetic fight-flight response, and then there's the parasympathetic response of freeze. So when we experience some kind of threat, you might be a person who gets really angry, right? You're the person who wants to engage and defend, and you're gonna punch that person in the face, or you're gonna dive into whatever that situation is. So patients who we see who get reactive, they get mad at us, they say they're gonna leave AMA, though in that case, we're starting to get into flight. All of that is part of a fight stress pattern. What about flight? These are people who maybe they just don't show up for the NST despite having had the audible decel in clinic. Or maybe they reach the point where I've had patients sneak out of back doors of hospitals when they just got so overwhelmed they couldn't be there anymore. And then there's freeze. And freeze is really interesting because it's easy for us to identify fight and flight in behaviors if we slow down to think about it. But if someone has gotten to a point where they're frozen and they're in a constant state of shutdown, that means that when they were met with a threat, the nervous system's automatic response is to come up with fight or flight. But it means that those options weren't safe. And this is often what happens with developmental trauma. In those first few years of life, when you are met with violence, with sexual assault, with parents who are physically or emotionally unavailable, we can't fight them, we can't run away, we're too dependent, and we freeze, we shut down. Next slide. So because any of those patterns are just walking around in all of our nervous systems, and any external cue can ignite them, it's really important to pay attention to what are the triggers in the environment that we're working in that might do this. And our particular environment of labor and delivery could not be filled with more potential for this kind of activation. So asking people to remove their clothes, the invasive nature of a lot of our procedures or a cervical check, Just the act of physical touch for some people is too much and overwhelming. We can never forget the intense power dynamics that exist between ourselves as the caregiver and the patient. Just being in the vulnerable position of being actively laboring and moving around the room, or maybe not wanting to be there. There's no privacy. Maybe we ask questions that are part of our job, taking a social history. However, they can feel so intense, or if you haven't earned a relationship with that person, that might be all they need to shut down or leave. And then even just the sounds and the smells, we get inured to them over time, but the beeping of the monitor, the beeping of the IV that's running out, the smell of alcohol sanitizer for someone with a history of alcohol use disorder, that could be a trigger. So kind of looking at the environment we're working in with fresh eyes and recognizing how the things that are day to day for our work life can be remarkably igniting for other people. Next slide. So to frame this, we're going to talk about the 4 R's of trauma-informed care. So the very first step is doing what we're doing now, which is to realize that there's a widespread impact of trauma, and to understand that trauma in and of itself always comes with the seeds for healing. Trauma itself is not the death sentence. The potential's within it to recover and come back to neutral. Once we've realized this, it behooves us to recognize what are the signs and symptoms of trauma in patients, in ourselves, in our families, and with other people whom we work with. Once we've recognized what trauma looks like, we respond. This hour we're spending together is about learning. This is the response. We learn how to integrate our knowledge about trauma into our interactions with patients, but taking that to the next level, we make it structural. We make sure that the policies, the procedures, the way that we practice as a collective is not traumatizing. And to do this, we're then doing that final R of doing the work of resisting re-traumatization. Next slide. So why don't we do this? Because when I say these words out loud, it's clearly beneficial. And I think it's important for us to name why we don't do this, because it doesn't mean we're bad people. It doesn't mean that we're not compassionate. Often there's not time, right? When there's 5 labors and people are delivering babies in triage, it doesn't feel like there's a lot of time to bring the sort of empathy that I'm describing. Sometimes we're just not aware of it. And that's where it becomes so important to think about those nervous system patterns I was just discussing, the fight, the flight, the freeze, and realizing that then you're engaging with a pattern, a nervous system pattern, and not just a wild person or a crazy person. Sometimes we have our own misconceptions, right? This is the work of stigma. And constantly, if we're going to be care providers in any way, shape, or form, we have to be doing the work of self-inquiry to figure out, where am I uncomfortable? Why am I uncomfortable? And in asking ourselves that, putting some light onto the shadowy parts of our consciousness so we can understand how to be better integrated and work with people in a less stigmatizing way. Sometimes we just don't feel like we have the tools. We're like, yes, I can see that they're very traumatized, but what do you want me to do with that? And sometimes we just don't have the training. Next slide. So we're going to do 2 things to talk about this. I'm going to go through 2 slides that in most trauma-informed trainings, what they'll do is they'll go through a bunch of different behaviors and ways of being that are trauma-informed. And I think that's great. But the next thing we'll do is I'm going to show you kind of a triad of ways and things to think about during a conversation. So we'll talk about details and then we'll get big picture. So to show up in a trauma-informed way, this means that you really engage the person. You recognize that relationship building is going to be a critical part of how you're interfacing with them and making sure that their medical care for themselves and their baby is whole and complete. You recognize the environment you're in. Pay attention to, do we have the fetal heart monitor all the way up to the top and the PIT IV is beeping, and how can we make things soothing? Act like you have all the time in the world. Give full attention. I know very well that you do not have all the time in the world, and I feel you so hard on that front. There are ways that we can come back to our own bodies, slow down our sensations, relate to gravity again, and really root, and come to the moment with a little bit more slowness. Make sure you're very clear about informed consent. That means talking about any procedures, making sure you've asked if you can break someone's water. That's a little bit more for providers, but it's a good example of something that we often do in the birth world and haven't asked about. Make sure patients know they have choice. I would say that this is something that is a very strong part of Mad River's history. And so augmenting that, make sure people know that they're in control. And that word is a powerful word to use. You're in control. This is your birth. This is your moment. What do you need right now? Validate. So even if people are saying things that we in that Western medical brain know, well, that's factually not true in any way, shape, or form, validate what they're saying and say that's normal. It's normal to feel that way. Allow people in non-COVID times to have support people with them. So even as you're building a relationship with them, recognize that hopefully they have other people whom they feel resourced in, and encouraging them to be part of the experience. Next page. So a lot of this relates to specifically how we do procedures. And for us, a lot of that has to do with pelvic exams. But making sure you ask if the patient's ready, let them know at the beginning that they can stop at any point, that you want them to feel safe. Encourage them to ask questions. Make sure you're keeping their body safe and draped appropriately. Make sure you talk to the person throughout. That being said, every once in a while, it's helpful to ask a patient. I'll often do this before something like a D&C to say, is it helpful to you if I talk to you through each step, or would you rather that I just go through the procedure? But making sure you get explicit consent about which of those ways of working they would like to proceed with. Encourage them to do what feels comfortable. Keep moving them towards their own inner wisdom and their own resiliency. And then all of this, and this final sentence, oh, and I just want to pause for a moment. Yeah, because this final sentence, obviously, at this moment in time and at this day and time, really deserves so much respect. But putting a high priority on culture, on race, on religion, on their sexual orientation, and paying attention to any historical and social traumas that may be relevant to the person who's sitting in front of you. Next slide. Okay, so as we were working to make this training, one of the things that I was thinking about was it's always lovely to list these things. And I actually really believe that especially nurses know these things. And we sort of forget them. And I think it's helpful to think about more of a process-oriented way to provide trauma-informed care. So one of the ways that I wanted to relay this is in this triangle. And so when I walk into a room and I know I'm going to meet a patient who, let's say she's there for a subutex start, and I've never met her, just shows in off the street, in labor, had a baby, and I get consulted to talk to her about buprenorphine. So I'm immediately sort of walking through in my mind the triad of these things. What's my goal for the conversation? And it may be, I'm just meeting you. I want to establish that there's trust here. I want to make sure that you're seen and heard, because we will get nowhere if people are not able to really feel like they've been met where they are. I might also have a very specific clinical goal. Maybe I need to get a COWS score on her, so a clinical opiate withdrawal scale, in order to assess whether it's safe to start Subutex or not. And maybe I need to talk to her about the fact that there will be a CWS consult, but there's some intention behind this interaction, and I'm always keeping that near the top of my mind. The next thing that I'm thinking about, the next thing that I'm thinking about is myself. What mood am I in? Have I been awake all night? Did I drive up and down the safety corridor to both hospitals like a crazy person? And am I really grumpy because of that? Or did I get a lot of sleep? Am I feeling like my heart is just overflowing with compassion? You know, where am I? And if I'm the former version of myself, then I need to check her at the door, right? Like, she has no business coming into that room, and I need to figure out how to self-regulate before I have this conversation. The other piece of ourselves, and this is both a momentary interaction and then again, work that I would really encourage all of us to be doing in a longitudinal way, is what are my biases? Implicit bias analysis of ourselves is so imperative, because we are all complicit in microaggressions and subtleties and ways that we're thinking about people that are far more judgmental and subtle and harmful. So doing that check-in with myself, I then am thinking about the patient. When I walk in, is she asleep in bed? Baby's in the bassinet over here. Is she sprawled out? Is she curled up in a little ball? I'm already trying to think about those patterns of fight, flight, and freeze, and get a sense from the affect she's bringing me. Is she pacing around the room frantically? What behaviors am I seeing? Which of those patterns is she hanging out in? Because I need to meet her there. And then the other thing that I'm thinking about for the patient is also something we could talk about with much more depth, but is her narrative. What's her story? And I like to start with the story of what brought her there then, like what's the story of this birth, this pregnancy, this baby? And then I like to talk about the story of the past. Well, tell me about when have you been sober before? How long did that last? How were you able to do that? And then where do you want to go from here? What have their hopes been about this pregnancy and this baby? And just really, again, present, past, future, just think of that as its own little triangle down there. And then all of this is happening in the milieu of three main values. So certainly compassion, that's a hallmark of what we do, and constantly recognizing that we're all cut of the same thing. We could be in the exact same situation at any point in our lives, but for other structural factors or grace or whatever you'd like to call it. So just always staying rooted in that heart-oriented approach. And then safety, making sure that the person feels safe. And so a lot of that can relate to posturing, the speed of your speech, your gestures. Are they going to feel comfortable if you sit on the corner of their bed with them, or do you need to sit on the opposite bed or in a chair on the other side of the room? Getting a sense of their physical and emotional safety and making that a priority for this interaction. And then the third value that I'm thinking about is anytime I'm speaking to them and they mention positive, something they're proud of. For example, I'll often ask people, well, have you ever been in recovery before? And if so, for how long, and how did you accomplish that? And I'll slow the conversation down to focus on that moment, because that's a moment of resiliency. That's theirs, that's lived. And you want them to feel the sensations in their body of what resiliency is like, because that's what they have to build on to create future stability in their recovery in their life. Next slide. So now we do the fun part. We're gonna go through some cases. And I absolutely want to hear your feedback and your thoughts and what you do with these patients. Every single one of you will have had one of these cases. In fact, you've probably all had all of them, because they are, I think, some of the bread and butter obstetric trauma versions that we see. So this is a 23-year-old G2P1. She has an unknown LMP and she shows up contracting. She didn't have any prenatal care. She will not let you check her. She's just screaming constantly, says you need to do something, but will not let you touch her. So when you feel ready to share, unmute yourself, and I would love to hear, we would all love to hear what you would do. What you have done, because I have been in this experience with many of you.
I would get eye level with her first, just sit with her.
Okay. So kind of get eye level, change your posture.
I mean, I feel like being just being where they are is the most important part. Just like, standing over them all the time is really frustrating. And I feel like it's really hard to really have a conversation with people when you're standing over the top of them. So the first thing I would do is change my placement, I guess.
Perfect. Yeah. So literal physical positionality.
Yeah.
And what else? What would other people do? Okay, we'll go to the suggestions. I'm not afraid to call on people. So there are some things that we could do. And Kristen mentioned one that's really perfect, right? So getting on her level, making sure that she feels like you're not an oppressive force in the room. But keep coming back to the word safe. There's actually been some body of literature on the word safe when people are usually this has been in ER settings. And one of the things that people will often remember more than anything else from their acute trauma in, Bay 1 getting transfused 8 units is someone telling them you're safe now, you're safe now. So there's a lot that we attach to that world. And labor is an altered state of consciousness. So, little roots like that of the word safe for people to come back to are really important. Think about anything physical. If she won't let you touch her, is there anything else that you can offer that could touch her? Water, heat, ice. One principle to walk away from with this is the idea of orienting. So encourage her to look around the room and pay attention to her immediate surroundings, right? When we are really traumatized, our relationship to gravity changes. We get tense, all of that movement happens in these muscles, and we want to run away, we want to get, and we're actually trying to get her to come back down, right? For a lot of different reasons. And one of the ways we do that is by look around. And we have labor rooms with windows. Look outside the window. What do you see? Hey, is there anything you see over there? Tell me what's pretty. That would be harder to do in this particular situation with screaming active labor, but at times that can be just the thing that the brain and the nervous system needs to break the trauma loop that it's in. Make sure that you can identify if there's other people she'd like there. In this scenario, she's come in by herself, but ask, is there anybody that I can call for you? Is there anybody that you'd like here right now? Validate and name the fact that labor is a loss of control. Right? This is a thing that is happening and moving through you. And saying that to her, then you can start to guide her towards things that are in her control. Can she come back to her breath? If she stands and rocks from side to side, is that something that she feels to be soothing? Are you able to offer her pain medication? In a different world, maybe we would have nitrous, something you could do without even checking her. But, you know, there's lots of options that we could work with. And then one thing that I like to do, especially when someone really seems like they are just so fraught, is ask them specifically, hey, what's happening for you? What are you thinking when you have a contraction? And people will tell you, I think I'm dying, right? I know you've all heard this, but getting them to say that, it creates a little distance, right? And it's that distance where we're able to bring in different parts of the nervous system. Bringing that name in is bringing the frontal cortex in, right? So we're invoking a different part than just that limbic system. Getting a little too far into neuroanatomy because I was reading some stuff earlier today, so thank you for bearing with me. But we're moving away from that limbic retreat reptilian brain into, oh, right, okay, I'm looking around the room. I feel like I'm dying, but I'm not dying. It does feel like it, and there's a baby coming. Okay, next challenge. Good job. All right, so you have a 24-year-old G2P1. She's at 38 and 2, based on an 8-week ultrasound. And she's been going through a 4-day induction for IUGR with normal Doppler. She's been stable on 16 milligrams of Subutex for 2 years and has a history of IV heroin use. She's had an epidural, finally complete. She pushes for 2 hours and is crowning, but then she just stops and says, I can't do this. I can't take him out. And that's when the baby Brady's and is in the 70s, and she's refusing to push. I feel like I'm just traumatizing you all by naming these situations because they're all I can like see on everyone's faces that they're like, yeah, no, we don't even want to think about it. So I know you've all been in these births though. And this is really common, like this particular moment of crowning and a person who's got PTSD in some way, shape, or form, they will just stop, right? We've all seen it. So what do? How do you coax her into helping us get this baby out safely?
It's Suzanne. And I think you just keep, you know, encouraging them, and like maybe I really believe in if the practitioner is not gonna, you know, massage the perineum and get them that baby down there, then I'm gonna do it. So I do that until they're crowning and until they're ready. So I know you have another, that would be something else because she might be like screaming, but yeah, I think that really works.
Yeah. Well, and what I'm hearing and what you're saying too is kind of relying on the relationship you've built with her over your labor.
Oh, I'm sure. Yes.
Yeah.
Of course. I mean, I wouldn't just go in there and do that.
Of course.
But,
Yeah.
you know, I just feel like, you know, that really helps if they're that close, and, you know, I can encourage them to just keep going, then I will like just make them breathe and push and all those things.
Yeah. Perfect.
We have Lori raising her hand.
Yes, I'm raising my hand. It's my first time. Wow. I would just say that I would try to empower her at those last moments as much as I could, like maybe saying something like, this is your chance right now to help your baby, your best chance to just get your baby out and help your baby right now. It's all under your control. You can do it, kind of making it powerful for her, like she has the power.
Oh my God, I'm so glad this is being recorded, because yes, that is such that language is awesome. You can help me push my breathing baby out anytime. That's great. Any other thoughts? Any other suggestions?
We have a raised hand from Cassandra.
Hi, Carrie.
Hi.
I'm not a labor and delivery nurse, but I would really reaffirm to her how far she has come, and that not only can she do this, but she really, to help her safely deliver this baby.
Perfect. Yeah, you are, again, naturals. You're naturals at this. Okay, let's go to the next page. So
do we have time for a couple more raised hands?
Yeah, I can't see the hands, so please call on the hands.
Okay, please jump in. Caroline.
Hi, Carrie, this is Caroline. I would also just try to really look her in the eye and just say, that is the baby. Nothing is happening to you. That is the baby. And then encourage her, like Lori was saying also.
That's perfect. I mean, really and truly, you guys are basically writing even better responses that are on the second slide. It's incredible. That's great. Perfect. So everything that you all said, Caroline just said this: orient to present time, make eye contact with her, remind her she's safe, reinforce her resiliency. This is exactly what Lori just coached us through. You've made it so far, and Suzanne, both of them. You validate how long this has been, how hard this has been, but you move through it. Again, so much has really already been said by you all, but continuing to resource in relationship. And maybe she has a great relationship with the delivering provider. Maybe it's what you've built over the several days of an induction. Maybe it's someone else in the room. And there are times when these women are also delivering alone. And then there are moments where you ask them to connect to an inner source of strength. Maybe it's a higher power, herself as a mother. I do think that this moment, especially for first-time moms, it's their moment of transition into a whole new identity, a whole new archetype. So rooting into that, or any other kind of ally that you would identify. And this was already touched on, but using some education is appropriate here. Just like Caroline said, that's the baby. We need to have a baby now, right? Perfect. Okay, one more case from me, and then we're gonna have Hannah Lippy talk to you. So a 30-year-old G3, now P3, is post-op day 3 after a repeat C-section for Shram at term who had no prenatal care. She presented in withdrawal from opioids and methamphetamine, and pain control has been difficult over the past few days. In the past, she had voluntarily surrendered parental rights, and she's been talking with this baby about how excited she is to go home with him. This is your first day meeting her, and the rounding physician comes on and tells you to call CWS. The physician hasn't talked to the patient about the referral. Okay. I see everybody's faces are they're just like, so thing one, go find your rounding physician and tell them to do their job, right? Like, we can all agree that that's a conversation that should happen. This happens too often, and that's part of the reason I use this example, is that there has not been an explicit conversation between the clinician and the patient, which is not really acceptable. So one, recognize that that might be your very first response, but even if it wasn't, how would you start this conversation?
I've had a few of these.
1, 2?
I don't know, a few. But I think, I don't know, when I first started at Mad River, it was really hard because I got kind of a lot of instruction to really not talk to the patient about CWS and don't really have those really hard conversations. And I feel like that was doing them such a disservice. And so for me, I've always felt like being honest with the patient is the only way you're going to have any kind of rapport with them. You're not going to do any good for anybody if you're not truthful and honest with them. And so, it's the law that if anyone is positive for any substance use, we have to call CWS anyway. I mean, like that's a mandatory reporting stuff, but it's a really hard situation. And obviously the conversation with the provider is the most important. Like that's going to have to happen immediately. But, you know, if she has no prenatal care, you're her person. You know, you may end up being her person. And so it's really important to get some kind of rapport with her and really just sit down with her and have that honest conversation. Honest conversation is the best part of any of this healing on any of it.
The power of disclosure. Yeah, that's huge. And what else? What other things would you want to think about if you're thinking about that triangle of what your goal is, what you're bringing, what you're assessing for the patient?
Laura, you raised your hand.
I was just thinking part of the story you said was that I was coming on to post-op day 3 and it was my first time taking care of her. So that puts a whole kink into it. I'm just wondering why the people who haven't observed her with the baby already, and you know, that's a problem that we have, is like I come on and not even knowing. I mean, I can hear a story that somebody told me from the night before, but you know, that's why documentation throughout the whole stay is so important for everybody to put down, you know, good and bad things that have happened or whatever, because so many times it comes down to my responsibility to report, you know, and I feel like I don't even, you know what to say to CWS in that case. And so I might ask the physician, you know, like we said, obviously we'd ask the physician to talk to the patient, but I'd want to know what the physician's primary concerns were, because if I don't know when I first come, I mean, I can call for a positive tox screen or something like Kristen said, but I don't really have a rapport or know that patient. So it is a problem, and we need to all document carefully, I guess, so we can have information. But I also agree with Kristen in telling people ahead of time. And also I try to get people prenatally that express concern or we know that are going to be a problem in the future. And I tell them, you know, you have to jump through hoops if you want to keep this baby. And I just flat out tell them that sometimes, you know, when they express interest in wanting to keep their baby and I can tell they're nervous about it. I'm just saying, you know, you're going to have to jump through hoops. If you can come in here with a negative tox screen, that's going to be great. If you can come in here and you have a place to live and you have a plan and, you know, everything, you've got to have it planned out. I just tell them there's going to be a lot of hoops. And unless you're motivated, you're, you know, it might be a problem keeping the baby. So.
But that's part of the biggest part about the conversation is like, you know, if you decide to use, what's the safety plan for this baby? You know, I mean, I sit down on beds every time this happens and I'm just like, what is your plan? You know, if you may or may not stay clean and that's okay either way, but if so, like, what's the plan for this baby? And that's what CWS is going to need to know. And like, you know, they have to sit down with their people, like whoever their support people are, and decide, you know, if they, you know, it's very likely or unlikely that they could use again. And if so, you know, what's the plan for this baby? It's, you know, it takes them out of it a little bit. Like, you know, you can choose to do whatever, but where's this baby going to go? Like, what's going to happen with this baby? You know, you may have your own struggles, but this baby doesn't. So what's a safe place for this baby to be?
Are there any other hands raised, Patty?
Nope, no other hands.
Let's actually go to the next slide. And then I want to slow down because Lori raised two really exceptional points. And one is actually kind of next level. It's taking trauma-informed care from the thing we're doing one-to-one. And she brought up the group, right? And it's the fact that, and I was purposeful in that case in making it the first time that you met that patient, because it means you have no relationship. You have apocryphal stories that have been handed out in probably limited sign out. And it does raise the importance of documenting, but also making sure we're giving a really clear social and structural sign out from day to night to day to night, right? So that if you are the nurse who has to pick up that conversation, it doesn't, so that we're all part of this together, so that we're all part of making sure that the trauma that can be a CWS consult is lessened. And so much of that is being clear in our communication with each other about the patient. The other thing that Lori said was this last check mark on this slide, which is about having an awareness of treatment options that might be available to her, or just having an awareness of how the CWS process works and being able to offer some education about that. And this year, Mad River's been part of a CMQCC quality initiative related to their mother-baby substance use toolkit. And one of their goals has been to have a binder, which Kristen, who is part of that project team, has worked on. So I don't know where that binder is living at this exact moment, but making sure that we're all aware that that's there. And maybe in a slow moment, taking time to, you could ask Kristen, you could ask myself, very soon you can ask Hannah Lippy herself, but making sure that you're able to find out like what is available. So if someone asks a question, it's not like, I don't know, you need treatment and I don't even know what that means. But starting to understand, even in just a pretty superficial way, what that might mean. Relatedly, all of those same skills about really slowing down, right? The other two cases were labor cases. We're postpartum, right? We've got rocking chairs in those rooms. Sit down, get to know her. The vitals will get done, the charting will get done. But just really, really recognize that this is a huge moment for this woman or this person's life as a new mother with their baby. Ask lots of open-ended questions, try to understand their story. I think it's really beneficial to find out if they've had other CWS involvement in their lives. And if they have, in this case, what was it like to surrender parental rights? What brought you to that place and decision mark? Really important to name that CWS is coming explicitly. I think we are all aware of the collective trauma that's happened to women when CWS shows up and no one has informed her, and that still happens. I honestly don't see that happen at either of the hospitals in Humboldt, but that still happens all over the country. And then really, again, finding out, and Hannah, Kristen named this, about what kind of support, who do you want in the meeting, as well as who might be able to be part of your safety plan going home. So I am blown away by just all of the collective wisdom that you all shared. Really and truly such a brilliant hive mind of trauma-informed wisdom here. So thank you. This ends my part, and I'm going to have Hannah Lippy start talking to you next.
I think Caroline had a question maybe before we move on to Hannah's part.
Yes.
Yeah, Mike, can you hear me?
Yes.
Yes.
My question, Carrie, is I've had the unfortunate experience where they actually have made a plan prenatally, and it seems like they know, and maybe even their provider knows, and maybe even somebody at social services knows, and then it just, for whatever reason, it's the weekend or something, and it all falls apart, and it ends up just being bad and re-traumatizing, and the baby gets taken away, even if ultimately it's going to come back to them. Can you help us navigate that?
Oh, Caroline, you could not have given me a better segue into Hannah Lippy. But yes, we can help navigate that. And some of the first thoughts I would have would be, ideally, we'd have early case management and social work. We all know that we struggle with social work resources at Mad River, but especially if someone delivers on a Thursday, we're looking at home on a Friday, or it's an eat, sleep, console baby who's going to finish their 96-hour observation on a Saturday, you call day one, like you call when they deliver, and just get the CWS process started.
Okay, is there any kind of way that they can ahead of time know, like if they're upfront, right? They're upfront about their use disorder, and then avoid having this weird thing happens where the baby can't go home with them even though they've got it all worked out ahead of time? I don't know. I just had a really bad one, and it's disturbing to me.
Yeah, no, and I also want to name the secondary trauma for you of that experience, because it feels awful to be part of something and to be witnessing something that is violent and that you don't have control over and that you just feel on a gut level is wrong. And I also want to resource for you the fact that here you are showing up, asking questions, and trying to figure out how to improve that. So thank you for that capacity that you have. There have been some conversations, and there are occasionally some counties where people are able to get prenatal CWS involvement or awareness. Humboldt is not a county where that happens, and I might have Hannah speak to this as well. But we have had conversations about the idea of like an embedded child and welfare services person for prenatal substance use patients, so that there can be some conversation about these plans prenatally. A lot of that has to do not with what happens on the clinical side, but with what child welfare has availability for. And Hannah used to work for child welfare, so again, her ability to speak to the details of that will be much better than mine. But big picture, right now there just isn't an avenue to do prenatal CWS work, which is a bummer and leads to some of the exact situations that you experienced, it sounds like.
I see. Okay, thank you.
But there are conversations happening about that. And I know that Dr. Stockton, I think in Shasta, they used to do this as well, or they had moved towards doing it. So there are places where that is done more. And yeah, the outcomes usually are better because there's been more communication, which
Carrie, Shasta County has had that in effect in the high-risk prenatal clinic for well over 10 years now. And it is, I'm so continually impressed by the community collaborative work and by all of the things that Humboldt County does. And it's the only area that I actually look at and say, this is one that we've really missed the boat, because it makes such a huge difference for hospital staff who are dealing with the trauma of being in the middle of these situations, of women, and helping them prepare in advance. And it's something that when you have the opportunity to advocate for that and really push that out, it may make a difference, because it is a county by county decision, and the counties that do have it have significantly less trauma for everybody involved at the time of discharge. So it's a great question, and every time you get an opportunity, I would encourage you to push that agenda and try and get that to be something that happens here, because in so many ways this county is incredible in the work that it does, and that's just that one little weak spot that we need to shore up.
Thank you. Perfect.
Thank you.
I do know there's been a few cases, sorry to interrupt, but there's been a few cases, I think one of the ones that Caroline's talking about, where they did have a plan ahead of time with CWS. They had a previous history. They had a tribal social worker. They had a DHSS social worker. They had the provider on board. They had the family all set up. Everything was great. And as soon as the baby was born, it was Thanksgiving weekend. Nobody was available. It was an absolute disaster. And I did take that to the Plan of Safe Care through the Yurok tribe to talk to them about what went wrong with that whole thing. And it was actually a pretty amazing experience to have the Plan of Safe Care people all there. So we had the Yurok tribe, we had CWS was there, Hannah was there. It was really like a really open conversation about like really what went wrong on this one that was really well planned. The baby was going to go to a very safe place with the other children, and so I think it's more about like us as nurses really being an advocate for that patient. And I know on that one, I ended up calling the supervisor and being like, I'm not going to talk to the social worker that was here. She was offensive, and I'm not going to talk to her. I'm going to talk to the one who's really going to get this job done. So it's hard because we end up having to be our own social workers a lot in our job, because we just don't have that support at Mad River. So just really being their advocate, be their voice, because they may not be able to be their own voice right now. So just be strong for them.
In the interest of time, I'd really like to move us on to Hannah's part. And if you have questions, please type them in the chat box, and we will make sure that those get answered along the way.
Thanks. And just like to add of what Chris and everyone's saying, like when you do speak up, that does make a difference. And I know from that conversation, it wasn't the Yurok tribe, it was the Karuk tribe that was also there. And I think part of this project and part of the Plan of Safe Care, which is a Yurok very similar project, is trying to figure out ways, what can we do to intervene before the baby comes. And I know that child welfare, that if there is a referral, they'll ask, hey, are you working with Hannah? or have they worked with the Yurok tribe? And they have said in some of those Plan a Safe Care meetings, child welfare, that they will take in consideration some of those assessments for those people who have worked. So I think the original question is that it's a work in progress, but the county is trying to come together with the tribes and figure out what can we do to really make those plans. So I'll kind of go into what the heck do I do. When a referral is made, I try to make contact with the person right away. We do say typically like two business days, depending on where I am. If I'm, in Lolita working with someone's going to take me a little bit of time to run up to Arcata. But I try to call them right away. And when I talk to people, as you guys have mentioned in this webinar, I try to be really transparent. I don't try to hide the fact that this project tries to work with people who have a history of substance use. That substance use, it could be their parents or partner. The idea for me is what can we do? What are some high risk factors and how can we really provide some safety and support? The next thing I do is explain that it's a free and voluntary program, and to just reiterate that this is their choice if they want to be involved. I explained where I got the referral from. So it could be one of you, it could be a provider, it could be Carrie. And I asked if they remember having that conversation. I think that's important because especially if people are in labor and lots of people are coming in and out, that people forget, they're tired. So just kind of giving them like, hey, this is who I am. This is kind of what that's about, and ask if they want to know more about the project. And if they're interested, I kind of explain and reiterate that this program really meets them where they're at and is determined by their goals because they're the expert of their life and they know what they would like help on. So it might not be, I'm going to go jump into waterfront recovery. It could be, hey, I really need help stabilizing my housing before I can do that and make sure my family is safe. Next slide, please. So some things I consider are pretty simple and things that all of us have talked about in this webinar is like the golden rule. If I was sitting across from me, how would I want to be treated? I try to slow down and watch my language, and I'll talk about language in a little bit. If whenever possible, I always try to ask permission. Can I sit down? And is it okay that I talk in front of your family members? Really trying to give them control whenever possible. I try to be curious. I've realized over the years it's a lot easier to be curious than be judgmental of kind of where their circumstances at. And to do that, asking those open-ended questions. It feels a lot easier even to ask those open-ended questions. There's a big difference between have you had kids removed before with child welfare to, tell me about your fears with child welfare. It kind of opens up different kind of conversations. I give them options and examples of how I've worked with people before. I've helped them, people getting to prenatal appointments and supported them when they maybe don't have a person to do that. Talk to them about Suboxone or calling free people for a food box. So I think those examples kind of help people figure out kind of what goals they might have. And then finally, I don't take things personally. Just a reminder, thinking about this trauma, like I'm a person with a badge, and that's really scary for some people. So thinking about if someone does not want to talk to me, just thinking about what potentially could have happened to them, and just keep that door open and calmly just say like, hey, if you change your mind, feel free to call or text me. So you could probably note a lot of the similarities that all of you and Dr. Griffin have talked about so far. Next slide. I also want to bring up kind of just what's happening with our brains and kind of that behavior. Our brains are pretty incredible. And if you think about some of these traumas that have happened to the people we work with or even ourselves, our brains try to protect ourselves. And some of that protection has kind of created these paths of how we respond to things. So if we look at like the mental state and then our cognition and then the areas that we're able to access depending on that is going to determine some of those behaviors. So if you have somebody who has, not their first child, they've gone to all their prenatal appointments, they have support systems with them. When they come in, you're kind of doing that initial assessment. They may be able to be really reflective and talk with you. If you have somebody who maybe is really worried about COVID, maybe they don't have all their support systems, they might be doing more of a flocking behavior, which is kind of asking different people what their opinion is and then kind of going with that. And then Carrie earlier had talked about someone who might leave AMA. Those kind of like, I don't know if this helps, but kind of looking at where they're at in their mental state will determine kind of some of those behaviors. It doesn't discussing the importance of helping create that calm and transparent environment really helps with kind of helping with some of these behaviors. Next slide. So talking about language, people first language, and that's what it is, people first. So if you think about someone you really care about, and maybe they're going through a hard time and the way that they cope is through substances. And for someone who's never worked with that person you care about, what feels better for them to describe them? Would it be that person's an addict or that person has with a substance use disorder? I think really focusing on the person first kind of shows that they're not just that one action. They could also be an auntie, they could be a teacher, they could be a grandfather, they could be a mentor, they could be a doctor. And so I really encourage people to kind of look at some of these more green check marks for how we can help kind of create a supportive environment, even just with our words. And I also want to point out some of these mutual aid meetings. That's like NA or AA. And in some of those meetings, people really identify with the word addict and alcoholic. And that's meeting them where they're at, and that's great. And if you're not in those meetings and you don't identify with those, I really would steer you to use more of the person first language. Next slide, please. I'm just going to go over a couple cases that I've worked with in the hospital that kind of shows kind of how I work with people. So the first one really emphasizes the power of being able to coach people. And I really feel like nurses like you all, you do this all the time. And I really see an impact of helping people kind of guide them and coaching them. So this case was referred by nursing staff and actually the social work case management team. And case management alerted me that they really thought the patient only agreed to the referral to the Humboldt Rise Project because of family pressure. And I also knew that the Eat, Sleep, Console was enacted. I also knew that they screened positive for opioids, which the client also confirmed later on when I spoke with them. So initially when I met with them, I talked to them over the phone and they arranged for me to come by the hospital, but asked if they could just have a few hours of sleep because their infant had kept them up all night. So I explained that to the nurses, which was really helpful because when I was supposed to arrive to come, the nurses called me and they're like, hey, hold on. The parent didn't get any sleep because child welfare has been here for hours. So can you just wait a second? We'll keep you posted. And then eventually I did actually get a call from child welfare and they're like, hey, we heard that you've been referred. The mom's totally ready to meet with you and we'd appreciate if you talked about Medicaid assisted treatment with them. Next slide, please. So when I met with the parent, they had a lot of family supports. And upon arrival, I asked if I could sit down. You know, I acknowledged like, wow, you just had a baby and you just had child welfare here for like 4 hours. Like you must be exhausted. I asked them if, you know, I could talk with them openly with their family. And I asked if I could kind of talk about some of their goals that they had. And they're able to share with me, you know, I really want to start Medicaid assisted treatment. I want to do an outpatient program because I want to be able to parent my child. They sort of like, I really feel like I need help coordinating with child welfare and that whole system. And they're like, you know, I was on WIC, but I really need to get reconnected. So from there, we just talked about all of those steps. So we took the first one, starting MAT. What does that mean? You know, and the patient, you know, they definitely broke down. They started talking a lot about shame. Like, you know I should have stopped. I just felt like I couldn't. And we kind of normalized that. And that's where you can give some of that education and kind of talked about how opioids affect the brain and kind of use that comparison with diabetes. And then I kind of talked about like, okay, with this COWS score, there's me some of these questions and this is the purpose of doing COWS, and really was transparent about it. And so when I got to the questions kind of about like when's the last time you used, and when I really reiterated and explained the reasons behind that, like, hey, I don't want you to get a reaction from Suboxone from starting too soon. They actually changed their answer and like, you know what, this is what I told the nurses, but this is actually when I last used. And just thank them for their honesty and highlight the steps that they've taken since they've given birth, since child welfare has been here, like all these steps that they've taken to try to make a change in their life. So from there, then we did our second one. We were able to call an outpatient treatment program. And the patient said, you know, I'm really scared to call. Will you help me? So that's what we did. I was on the phone, but they were there with me to kind of chime in. And then the second thing, we're like, okay, we need to update child welfare and let them know when we have this intake appointment set up. And at that time, we're like, okay, let's do this one together. So we're both able to talk on the phone. And then when we got to the third goal of like reconnecting with Wick, the parent was like, you know what, Hannah, I got this. Let me call, but please just stay here in case I have questions. And they were totally able to do it. It was great. And then it was almost like scripted, like somehow it was made to happen. After that, their baby started crying. And so the family's rushing over to try to console. And the mom was like, hold on, I got this, I'm mom. And then a nurse came in, they're able to like work on swaddling, and the mom was totally able to do it. And she had a smile on her face, and I was just really proud of her. The outcome of this particular case is that they were able to start on medication-assisted treatment. They were able to complete their intake for outpatient treatment and continue to update child welfare on their own, and their infant is still in their care and doing really well. Next page.
I do want to take a quick pause and just take a temperature check because we are at time. So I want to be respectful of all of our participants and just ask, are folks okay to go through a few more of these case studies, or would you like to use this time to ask questions if there are still burning questions? I just am curious to hear from everyone.
I'm okay with continuing.
Great. Okay.
I'm okay with continuing.
Wonderful. Thanks, everybody. Okay, sorry, Hannah. Just wanted to make sure that we're still okay. Thank you.
All right, our next case was also referred by nursing staff, and this may be familiar to some of you. The staff reported that there was no prenatal care. The family was homeless, and the infant was in the NICU at that point. They said that they didn't do a 4-piece screening, and that there was a toxicology screen positive for methamphetamine and cannabis, which was later confirmed by the patient. So initially I met with the patient alone, and the patient initially was confused about the referral, but as we talked, they accepted services and were able to kind of discuss their ideas of what recovery would look like for them and what kind of their goals were. So they're able to talk about how they felt like they used substances, methamphetamine and heroin, as a coping mechanism for their mental health, and shared that in the past they had tried Suboxone once by cutting up a friend's dosage into little pieces, but were interested in actually trying an official MAT program with a provider to see how that would help. So we talked about what that would look like and realistic for them, and they felt like they named a specific town where there was a MAT program where they could live with family who could help them kind of take care of their child and allow them to kind of do this outpatient program. Next slide, please. So I communicated kind of what was happening with the nursing staff. I always try to keep them in the loop. And then I was able to find the specific MAT application for that particular program. And when I came back, I found one of the parents in the NICU, and I brought them the application, and they were visibly frustrated. And I kind of, checked in what was going on. They said, so many different people keep coming in and out, and they felt like it was disrupting their bonding with their child. And so we just talked about making a plan that the next day I would come by and that we would work on the application together in the morning. And as I was leaving, child welfare came up, and they're like, hey, we're so glad you're here. We want to invite you to this child and family team meeting the next day. And they said there is a safety plan. So child welfare has to make a safety plan when there is a specific safety threat. And so typically they make it with the parents. And if they're unable to make a plan, then they have to remove. After they make a safety plan, typically within 3 days, they're supposed to have some sort of child and family team meeting where the family and different supports come together and they try to make that long-term goal. And again, if a goal is not able to be found, that's typically when a child is removed. So they're really important meetings. And I think Kristen kind of talked about some of those safety plans in some of those meetings. So again, I communicated to the nursing staff that child welfare will be here the next day for a meeting. And we kind of talked about with the safety plan, the patient needed to be supervised by their family. They couldn't be left alone. And so that family might be taking over some of those eat, sleep, console practices with that policy. So again, everyone was kind of on the same page and still be able to be supportive to the family. So the next day I arrived I was assuming to be completing an application with the parent, and the parent said, you know what, change of plans, and they explained that they have had experience with child welfare in the past, and that if there is a baby, 3 and younger, typically if there's a court case, that parent has about 6 months, but really it's more like 4 or 5 to become sober and housed. That is extremely difficult for people. So they felt like that's not realistic. And the best thing we could do for our child right now is to create a guardianship with our family members. And they felt like that was the best thing they could do. And they wanted help kind of explaining that to child welfare. So that's what we did. We had a child and family team meeting, and child welfare was really receptive and kind of listened to the family and explained that this is hard and guardianships don't happen immediately. So they would have to legally and physically remove the infant from their care, but then they would place with family members. So after that meeting, I felt like the parents still felt validated that they were able to make a plan. I think that's the goal of this case plan, is to show that even if parents aren't the place that we might want them to be, they still have a voice and can make really good plans for their children. This particular family, we talked about some harm reduction, got them transportation to get to a safe place and got them a meal, but then their phone number was disconnected and lost contact. And then our final case is the importance of screening for tribal affiliation, which I know that Mad River does way more than St. Joe's Labor and Delivery. So this person was released from jail, and they were referred to the St. Joe's ED Bridge Project, which helps people get started on Suboxone. And then there's a particular staff who can help them get connected to Open Door, or whatever that next step is. And that person found out that this person was pregnant. So I came and met that person, and they explained that they were very interested in navigation services, but lived out of county and wasn't sure what to do because this program's just for Humboldt County. So I did a screen for tribal affiliations and found out they're with the Yurok tribe. So I was like, hey, do you know that the Yurok tribe has a plan of safe care, and it's pretty much the same program as me, but with your own tribe? And like, I had no idea. So we're able to still kind of obtain a consent to be able to coordinate with the Yurok tribe. We were able to get them back to their county, provide some transportation. They were able to start Suboxone, and then we connected them to an outpatient in their own home county. And that person continued working with the Yurok Plan of Safe Care. I think that's it for me.
Thank you, Hannah. I just want to open up the floor for questions now. Anybody, please feel free.
I have a comment.
Please go ahead.
This is Patricia, and I used to work in Chicago, and I had a very insightful moment once learning about people that have, I'm trying to think of the proper word because I always say the wrong one, developmental delays, and that how you really have to have a plan to work with them, that they don't, things that would make sense to most people, they don't necessarily always compute, and just throwing that out there.
Yeah, thank you for that, Patricia. May I ask you a question?
Sure.
What was there anything that you heard in the last hour that you feel like is reflective or helpful for that population in particular, that brought up that particular memory of working with that population?
Well, I was at the University of Illinois at Chicago, and they had we had an inpatient psych unit, and it was just that the nursing assistant brought the baby, and this isn't something that would happen with us, but they brought the baby, and then, to say goodbye, and then it was like too much, and we had to pry it was awful. We had to pry the baby out of her arms, and then she took off all her clothes and lay naked on the floor, and the psych person just took me aside and said, oh yeah, this is, a special situation. So when people have developmental disability, challenges or whatever. It's just, you just have to understand that they just can't compute. It doesn't make any sense. And, just make, ever since, it was just one of those cardinal moments for me. So it doesn't necessarily apply, but it's just the idea that if we did have, somebody like that, we just have to give them extra kid gloves, I guess.
Yeah, well, and when I think about the question of how would I apply trauma-informed principles to a developmentally delayed individual, I would be very mindful of touch, maybe be more cautious depending on the patient, but I would just keep so much of that as affect and how we show up in the room, and continuing to come back to soothing and safe language. And I also just want to name what a moment. It sounds like years later, that's something you're still able to see and carry that image.
Yeah, and we were actually doing all of that. We were very sweet and nice, and the nursing assistant was, had known her and was really looking out for her. But it was just like her response. She just couldn't help it. She just didn't know what else to do, and she just ripped off all her clothes and lay naked on the floor. And it was just really dramatic. It was just one of the, it was just one of those things, because we were actually doing all that stuff. And it was just one of those things. It was like, oh, okay.
Yeah.
Anyway, it was just a little something.
Thank you.
We also have a question from Lori, and then Shoshana, and then Aaron.
Actually, I think that was from before I had a question. Well, I was going to say something and then she wanted to not take questions. So that was from before. It just never got turned off. Sorry. Bye.
Nice. Was it Shosh?
I just wanted to ask what I think also came up on the chat, which is if we are meeting a patient that we think needs some more resources or to be connected with Hannah, what is the process for that?
I can speak to that a little bit. So Hannah's role in the community is still very new. The RISE project, as a team, thought that we should sort of start out with a smaller pilot project and just kind of go out the gate with her services with St. Joe's OBGYN. So that's where she started to see clients there and in the hospital. And so we're certainly hoping to work towards expanding her services to Mad River and then to other practices in the community. But that's something that we're working towards.
And hey, Patty, this is Jessica. And hey, everyone. Sorry to be the voice from like afar in the black box, but I'll also say that I think that conversations are sort of underway to like make that real for referrals from Mad River directly.
Thanks, Jessica.
And just to point out that because Hannah may have been, or that a patient or client may have been referred to Hannah already, Hannah may already be working with women who are coming in to deliver at Mad River. Not as highly likely right now as if they walk into St. Joe's, but there may be some places where she's already working with your patients. And if that's the case, you can just reach out to her using her phone number to make that connection.
Yeah, thanks for saying that, Candy. I was thinking that, like, yes, even though Mad River isn't technically sending out referrals yet, I've definitely been to Mad River and worked with people both prenatally beforehand, kind of working on those plans and kind of helping with coordination with child welfare and other means that are more short term. So if you haven't seen me yet, I expect you'll see me in the future.
Hello, I had a question. If a patient is out of county, then you won't be dealing with them, or will you still be helping them in the hospital? And also, if they're tribal, then will you help us refer them to the tribal navigator, or we'll need to get a hold of that person, because we had somebody a couple of weeks ago, and I did reach out to you. I got your number from Kristen, and left a message, but she was out of county and she was a tribal member. So I guess there was some confusion on our part about your role. And just an aside to that, I tried to get a hold of you through St. Joe's, and they had no idea who you were. So I'm like, she has an office there, and they're like, no, she doesn't.
So, yes, like the goal of the project is that I'm supposed to be the easy call person. So if they're tribal, if they're out of the county, we can still kind of consult and talk about what are the options. And that's what I would do specifically with that patient. Because there might be some tribal people who are like, no way, that's my auntie, I don't want to do that. And some people are like, no way, I had no idea. That's great that my tribe can do that. Connect me to that person. So this project, it's supposed to be easy to just contact me. And I'm sorry about St. Joe's. There's a lot of people here, and I'm not surprised that would happen. But if we set up a specific referral, it would kind of, Patty and the team would work with Mad River to figure out what's gonna best actually work for your team. So for some places, it's a referral that has my work cell number that you can call or text. There's like, is it this person's screened? What are the issues? So we try to make it as easy as possible and what's gonna actually work with your workflow.
There's a question from Shoshana. Shoshana, did you have a question?
I just asked it. Thank you. Thanks for this training. This has been really helpful.
Thank you for participating. I see another question from Lori, or is that the same raised hand?
That's the
Okay.
Okay, that's the same one. Yeah, that nobody's getting rid of it. But I will just go back and quickly say, I mean, it's like you said, CWS historically has not wanted to know anything until the baby is born. Don't call us until the baby's born. And that's always been their mantra. So I'm glad that things are moving away from that. And I just hope we can make more plans prenatally and, you know, have people aware of the situation and stuff. So it used to kind of be the theory, like, don't tell them or they're not going to come there and deliver. But if every hospital tells them, you know, and everybody's on the same page, you know, it just seems to me it's better to know beforehand and work out a plan. But that's it. But I didn't raise my hand, so, but I do feel like it's a problem.
Yeah, and I can just add a little bit to that. Just from working there, what we were told is that legally they cannot intervene until a child is born. And so they, at a screener level, kind of where who takes reports, they can put like info only reports. So if you looked up that parent, potentially you could kind of see some of the information if people had called before. But what they're supposed to do is try to refer out to different programs. So typically that's family resource centers or community resource centers or public health. And so that's one way that public health potentially could reach out and refer to someone. But some people in this population are really uncomfortable with public health for different reasons. And so this is a way that this project could be kind of like a loophole to kind of fill that gap. Like, okay, if you don't want to work with a nurse, but here's someone you could still work with on particular goals. So that's just my experience from child welfare working with there on that stance.
We definitely have a really difficult position because we don't have social workers at Mad River that are super supportive or participating very often, as we all know. But the Yurok tribe and the Hoopa tribe are trying to get together these clinical navigators that are specific to each location. So they have a Wichipek, a Klamath, Hoopa, and Kamau and all of they're all trying to get their own clinical navigators that are supposedly going to be able to come to Mad River Hospital. We have a lot of Native population at our hospital, and so, you know, getting someone from their tribe, their specific clinic, to come to us to meet them at the hospital when we have a patient who has no prenatal care and delivers by ambulance or comes by ambulance and has no support person. How do we help that person? I think that's the biggest scare that we all have, you know, like do we just throw her back out into the world with, you know, the baby's now taken and the mom's like out in the world again, you know, like how do we help her? And so there's supposed to be these clinical navigators for each part of the tribe that will be able to come to the hospital and actually do an intake at the hospital and follow them from there out back into their community. So that's the goal with Plan of Safe Care. That is, I mean, Hannah is part of that whole thing for sure, but it's definitely very tribal affiliated. So that's something a little bit different that they haven't quite, I think maybe Hannah's can help me on this a little bit more, but they have not hired all of those people, but that's their goal. So that would be great for Mad River, because that would be really beneficial for our clientele for sure.
Just the last thing I wanted to, oh, go ahead. There was a question? Okay, really quick. The last thing I wanted to mention is that this, if you can see my screen here, there's, as part of this project, we developed the North Coast Resource Hub. So here's the link for you. I can put it in the chat box as well. This is just another resource that's available to you that is an online, mobile-friendly resource guide. And it's sort of specifically tailored to pregnant women with substance use disorder. So here we included most of the MAT treatment centers, as well as inpatient treatment centers, family resource centers, food bank, many resources throughout the county that might be helpful for patients to access. So that's there for you too. Any other finishing thoughts or questions? Hey.
Thank you all so much.
Thank you. Thank you, everybody.
And yeah, just thank you for your presence and your participation. Have a good night.
Thank you.
We'll send these recordings to everybody on the slides too. Thank you for your participation.
Thanks everybody.
Thank you. Very informative. Thanks a lot.
Thanks, everyone.
Thank you, Hannah.